This presentation will be covering hormonal contraceptives, and I'm Bethany Von Hoff. According to a CDC national survey, 81.9% of sexually active women ages 15 to 44 have used an oral contraceptive at some point in their lifetime. Oral contraceptive use varies based on age, race, education, marital status, and health insurance. In a 2013 study done here at the University of Minnesota, 42.4% of sexually active students report using birth control pills, and 6% report using an intrauterine device. This table highlights the effectiveness of different pregnancy prevention methods. You can see that this table provides information about the rates of unintended pregnancy within 1 year with both typical use and perfect use. So perfect use would be taking it exactly as prescribed, never missing a dose, being consistent with the time of day, etc. But typical use is more reflective of how the average patient takes the medication. So you can see at the top there's Mirena, the intrauterine device, has a 0.2% unintended pregnancy rate. As you go down the table, the effectiveness decreases, all the way down to spermicides, which have a 29% unintended pregnancy rate within 1 year with typical use. Let's start by doing a quick review of the female anatomy. There are 2 ovaries, 2 fallopian tubes, the uterus, the cervix, and the vagina. The ovaries store the eggs, and ovulation is when an egg is released from the ovary into the fallopian tubes. The egg travels down the fallopian tubes, and if it is fertilized, it then implants in the uterine wall. The uterus is a hollow muscular organ where the fetus develops. The lower portion of the uterus is called the cervix, which opens up into the vagina. To understand how hormonal contraceptives work, we have to think about the normal menstrual cycle. So starting at the far left of this picture is day 1 of the cycle. FSH, or follicle stimulating hormone, which is the orange line on the graph, causes follicles, which include the egg, to start developing. The follicles are pictured as the purple circles on the top of the picture. The follicles are in the ovaries and they begin secreting estrogen, known as estradiol, which is the pink line. You can see that the concentration of estradiol starts to go up as the cycle progresses. Estrogen stimulates the growth and thickening of the uterine lining, which is represented at the bottom of the picture. Luteinizing hormone, or LH, which can be seen as the blue line, is secreted steadily until about day 14. Around day 14, the rising estrogen concentration triggers what's known as an LH surge, which you can see as the rapid increase of LH, the blue line, around day 14. This LH surge triggers ovulation. During ovulation, the follicle ruptures, and this releases the egg into the fallopian tubes. The follicle, without the egg, now turns into the corpus luteum, which is the yellow shapes on the right of the picture. The corpus luteum begins to secrete estrogen and progesterone, which are the green and pink line. Progesterone helps prepare the uterus to receive the embryo by increasing the thickness and the amount of nutrition in the lining. If the egg is not fertilized and implantation into the uterus wall does not occur, then the corpus luteum degenerates. The concentrations of estrogen and progesterone drop, and then menses or menstruation occurs, which is the shredding of the uterine lining that has been built up. Then the cycle begins again. Okay, that cycle can be a little complicated, so let's take a second to pause and think about it and answer these quiz questions. If you are unable to answer these questions, take some time to review the previous slides and your notes. So when is estrogen at its highest concentrations in normal menstrual cycle? And what about LH and progesterone? When are they at their highest concentrations? For estrogen, it is highest right around mid-cycle, just prior to ovulation, and then it increases again in the later cycle when more estrogen is secreted by the corpus luteum. LH, the luteinizing hormone, is highest at the LH surge that happens at mid-cycle that's responsible for triggering ovulation. Progesterone concentrations are highest in the later part of the cycle after ovulation. The corpus luteum is formed after ovulation, and it is responsible for secreting larger amounts of progesterone. After ovulation, the egg can be fertilized for about 36 hours. Sperm can live in the normal uterine environment for about 48 to 72 hours. This means that there's typically a 4 to 5 day period of fertility within a normal cycle. People can use this information to either try and avoid getting pregnant. If they want to avoid this period of fertility, this is often called natural family planning. Or if someone is trying to get pregnant, they may try to target this window of fertility. There are different methods to try to measure the fertility, including kits, but also measuring your daily temperature. Fertilization, when the sperm and the egg join, happens in the fallopian tubes, and then the fertilized egg travels down the tubes into the uterus and implants into the uterine wall, typically 4 to 7 days after ovulation. So a woman is considered to be pregnant once the fertilized egg implants in the uterus wall. Hormonal contraceptives work by interfering with the normal menstrual cycle that we talked about. Most of the hormonal contraceptives contain an estrogen and a progesterone that are taken daily. However, we will talk about other hormonal options as well. The primary effect is on the ovaries to inhibit ovulation. The hormonal contraceptives work to inhibit the release of FSH, the follicle-stimulating hormone, and LH, the luteinizing hormone, through negative feedback. Without these hormones, ovulation does not occur. Ovulation is triggered by the LH surge. The high levels of estrogen and progesterone in the blood from the hormonal contraceptives turn off the FSH and LH so they are not released anymore. This is the primary effect, but ovulation isn't always inhibited, so this is where the secondary effects come into play. In the cervix, hormonal contraceptives are responsible for thickening the cervical mucus, so sperm has trouble getting through the cervix and into the uterus and fallopian tubes. In the uterus, estrogen and progesterone are usually responsible for causing a thickening of the endometrium or the uterine lining. However, when the hormones are taken daily, they actually cause a thinning of the lining, which prevents or decreases the implantation of a fertilized egg into the uterus. There are many uses for hormonal contraceptives. They obviously can be used for contraception, but they also can be used for the treatment of acne. Usually the estrogen component is the most helpful in treating acne. Also, hormonal contraceptives can improve premenstrual symptoms or dysmenorrhea, which is painful menstruation. Hormonal contraceptives can also improve endometriosis symptoms. Hormonal contraceptives can also reduce the risk of endometrial, ovarian, and colon cancers, as well as ovarian cysts, ectopic pregnancies, and iron deficiencies. Ectopic pregnancies are when the fertilized egg implants in the fallopian tube or somewhere else outside of the uterus. This can be very painful and dangerous. Hormonal contraceptives are not usually given specifically for these secondary reasons, but they can provide these benefits and can help in deciding which method to choose. Side effects from hormonal contraceptives can be related to either the estrogen or the progestin component. In general, when someone starts on a hormonal contraceptive, we tell them to wait at least 3 months or 3 cycles for the body to adjust to the new hormones and to adjust to the side effects, unless they are severe side effects. Breakthrough bleeding is a common side effect when first starting, but it usually subsides on its own. Nausea, headache, and breast tenderness are all related to too much estrogen, whereas acne, fatigue, and weight gain may be related to too much progestin, although there is controversy if hormonal contraceptives are really associated with weight gain or not. If there is breakthrough bleeding mid-cycle, it typically means that the hormonal contraceptive contains too little estrogen. And if the breakthrough bleeding occurs during late cycle, that's typically due to too little progestin. It's important to note here that we often refer to hormonal contraceptives as the pill. However, there is not just one pill that can be taken. There are several different hormonal contraceptives that have varying concentrations and types of hormones within the pill. We'll talk about this later, but this can be very important. Some women will try one kind of hormonal contraceptive and have side effects or find it not effective for helping with acne or dysmenorrhea, and she may just need to try a different combination of hormones or a different level of hormones. Many women do not understand how many options they really have. Most of the serious side effects are related to the estrogen component of the contraceptives. The first serious side effect to consider is thromboembolism or blood clots. This can be a clot in the legs or a clot in the lungs, which is called the pulmonary embolism. Estrogen increases the risk for blood clots. The risk is 3 times higher in women taking oral contraceptives. However, it is important to note that the overall risk for thromboembolism in non-smoking young women is incredibly small, so even when you triple that risk, the risk is still low. Being pregnant actually has a higher risk of thromboembolism, so the risk of a clot from taking oral contraceptive is still lower than the risk of getting an unintended pregnancy and then that clot risk, which is higher. The risk for stroke is also increased, especially in women over 35 and heavy smokers, which are considered to be 15 or more cigarettes a day. For these reasons, we need to monitor who should be taking oral contraceptives and who shouldn't be. Finally, estrogen can increase the risk of heart attacks or myocardial infarctions. This risk is slightly higher for women who are obese, have hypertension or diabetes, so women who already have risk factors for heart disease, but this risk increases much higher in women who smoke as well. Because it is clear that for some women there are greater risks for taking hormonal contraceptives, the World Health Organization and the Centers for Disease Control and Prevention identified a list of contraindications to hormonal contraceptives. So these are women who should not use the combined oral contraceptives because the risk outweighs the benefit. This includes women who are pregnant and women who are breastfeeding. Women who are breastfeeding should use a progestin-only pill, which we will talk about later in this presentation. Next, several of the contraindications are related to the serious adverse events that we just talked about. So women with a current or history of a clot, cancer can also increase the risk of a clot as well. Women who have migraines with aura should not use the combined oral contraceptives. And breast cancer is also a contraindication because the estrogen could accelerate the growth of cancer. As I started to mention earlier, there are many different kinds of hormonal contraceptives. However, most commonly they come in a 28-day cycle where there are 3 weeks of active pills and 1 week of inactive or placebo pills. During this inactive week is when menstruation occurs. There can be monophasic, triphasic, or extended cycles. Monophasic means that there's the same level of estrogen and progestin throughout the whole cycle except for the placebo week. Triphasic means that the dose of the progestin and sometimes the dose of the estrogen change 3 times during this cycle. For each of the 3 active weeks, there's a different dosage of the hormone. This is intended to more closely mimic the normal hormonal menstrual cycle. Extended cycle packs that are ones that come with active pills for 3 months and then a week of placebo pills at the end of the 3 months. And there's reasons for why you might do the monophasic, the triphasic, or the extended cycle, but that goes a little bit beyond the depth of this course. There are also 3 different ways you can start taking the hormonal contraceptives. There's quick start, Sunday start, and first day start. Quick start means that you just start using the hormonal contraceptives on the first day you get your prescription if you are not pregnant. Sunday start means you start the pack on the first Sunday after your period starts. You may still be in the middle of your cycle when you start the pack on the Sunday start, and that's okay. This is often the preferred method because when you do it this way, you typically do not have your period over the weekend. Finally, Friday start is when you start the first day of your next period. This method is sometimes chosen because you do not need to use backup protection for the first cycle. Hormonal contraceptives are most effective when they are taken at the same time each day. Information about missed pills can be found in the package inserts. Missed pills are probably the most common cause of contraceptive failure. It is always recommended to use backup methods with missed pills, especially if you are unsure of how to make up the missed pills. We've been talking a lot about the oral hormonal contraceptives because these are the most common. However, hormonal contraceptives are also available in the patch and ring form. Ortho Evra is the patch, and it is applied once weekly for 3 weeks, and then you have a 4th week where you are patch-free. This is the same idea as the placebo week with the pills. It releases hormones slowly through the skin. There are similar side effects to the oral tablets, but more skin reactions from the patch and a potential for higher risk of blood clots. The Nuva ring is a vaginal ring that is inserted vaginally and left in place for 3 weeks. The ring is then removed for 1 week and a new ring is then inserted. This also slowly releases hormones over those 3 weeks. If the ring falls out or is taken out for over 3 hours, there can be a decrease in the efficacy. This is the equivalent to a missed pill in oral contraceptives. If the ring falls out or it is taken out, you can rinse it and put it back in. The hormone release is triggered by your body heat, so if you are rinsing the ring, it's important to just rinse it in lukewarm or cold water, as hot water could cause the release of hormone from the ring. If your ring is out for more than 3 hours, you should use backup protection. The ring has similar side effects to the other options discussed, although there is a noted increase in vaginal discharge. Let's take a second to think about what you've just heard. Would combined oral contraceptive be a good option for a nursing mother who just had her baby 3 weeks ago? Why or why not? And how about a 37-year-old female who smokes 20 cigarettes per day? According to the World Health Organization and the CDC guidelines, nursing is a contraindication to using combined oral contraceptives because the estrogen component can decrease milk production, so the better option would be the progestin-only mini pill, which we will talk about in a few slides. The 37-year-old smoker is also contraindicated. Smoking already increases the risk for heart attack and stroke, and the combined oral contraceptives increase this risk, especially with her age over 35 and the quantity of cigarettes she smokes daily. There can be drug interactions with the progestin only and the combined hormonal oral contraceptives. Some antibiotics can alter the normal flora of the normal bacteria found in the gut, which can reduce the efficacy of the contraceptives. Since this affects the gut, it only applies to the oral contraceptives, so not the ring or the patch. While there's still some controversy about how much of an impact antibiotics have on the efficacy of contraceptives, it's still generally recommended to use a backup method of contraception while you're taking the antibiotic and for 7 days after. Anticonvulsants or anti-seizure medications can also induce the enzymes that degrade the hormones, so this increases the metabolism of the hormones so they are broken down in the body faster. This decreases the effectiveness of oral contraceptives. This is an especially important drug interaction because some anticonvulsants are known teratogens, so it can be dangerous to become pregnant while on the anticonvulsants. So for a lot of these women, it's recommended that they are always using 2 methods. Finally, St. John's wort is an herbal supplement that is often used for depression. Similarly to seizure medications, it induces the metabolism of the contraceptives and can make them less effective. St. John's wort can be bought over the counter, and again, many people do not think about the drug interactions of over-the-counter medications, which is why it is important to talk to your physician or pharmacist about starting over-the-counter medications. So far, we've been talking about the combined oral contraceptives that come in both progesterone and estrogen. However, there are progestin-only contraceptives. These work similarly to the combined oral contraceptives because they still have the progestin component, but they are missing the estrogen component. They still work to suppress ovulation by inhibiting the release of LH, but without the estrogen component, this inhibition of ovulation is not as reliable, so the secondary factors play a more important role. So again, in the secondary factors, we're talking about the thickening of the cervical mucus, making it difficult for sperm to pass through, and the progestin can still be responsible for thinning the uterine lining and preventing the implantation of a fertilized egg into the fallopian tube. And progestin also works to slow the mobility of the egg or sperm through the fallopian tubes. Progestin-only contraceptives come in 3 main dosage forms. The oral form is called the mini pill. There's also Depo-Provera, which is an intramuscular injection given by an IM shot every 3 months into the muscle, and the hormones are slowly released. Spotting and breakthrough bleeding are pretty common when they first start on Depo-Provera injections, but usually after a few months that goes away, and typically a lot of women do not get their period while they're on Depo-Provera, and this is called amenorrhea. Weight gain is a common concern with using Depo-Provera, but there are conflicting results in the studies if it actually is responsible for causing weight gain. Use of Depo-Provera is associated with a decrease in bone mineral density, but this is mostly reversed after women stop the injection, and it hasn't been shown to increase the risk of bone fractures later in life, but you should still make sure that women on Depo-Provera are still getting adequate calcium and vitamin D. Some people think that Depo-Provera is very convenient because it's only once every 3 months and you don't have to think about it daily. But for other people, this is more inconvenient because they may have to schedule an appointment every 3 months to make sure they get in to get the injection. So again, it's a little bit of personal preference. Finally, Mirena is an intrauterine contraceptive. It is inserted into the uterus by a healthcare professional, and Mirena releases progestin into the uterus at a lot lower levels than the oral contraceptives, and it can work for up to 5 years. It is not as common to get amenorrhea as with Depo-Provera, but it does happen for some women. Side effects are often similar to other contraceptives, such as nausea, headache, and fatigue. It's often used for women who have already had a child, but it can be used for women who have not yet had a child. It can stay in for 5 years, but it also can be removed at any time. The mini pill is what they commonly call the progestin-only pill. This is for women who cannot take the estrogen component. Most commonly, this is seen in breastfeeding women, as we said that estrogen can decrease the milk production. Also, this is common for women who have had prior thromboembolisms or at high risk for clotting. They also may be good candidates for the mini pill. It is still taken once daily, however, it is much more sensitive to the timing of the dose. So if you are more than 3 hours late taking the progestin-only mini pill, there's a much higher rate of failure, and it is equivalent to missing a pill on the combined oral contraceptives. If you're more than 3 hours late, you should be using backup protection. Breakthrough bleeding is also more common since the mid-cycle bleeding is caused by too little estrogen, and the mini pill does not contain estrogen. Let's take a second to think about the difference in mechanism of action between the progestin-only mini pill and the combination oral contraceptives. The main difference is in the ovaries and the mechanism of action. The combination of estrogen and progesterone is more effective at inhibiting the release of FSH and LH. Without the release of LH and FSH and the LH surge, ovulation cannot happen. And in just the progesterone mini pills, this inhibition of ovulation is not as reliable. The secondary effects on the cervix, uterus, and fallopian tubes, though, are really not that different because it's the progestin component that's really mediating all of these effects, and the progestin is in both the mini pill and the combination products. Finally, the last form of hormonal contraceptives that we'll talk about today is the emergency contraceptive, or Plan B, sometimes called the morning after pill. Plan B is progestin only and contains the progestin called levonorgestrel. This is the same progestin that is in combination products such as Elise and Seasonique, but it is in a much higher dose in Plan B. It has the same mechanism of action as the mini pill, inhibiting ovulation, thickening cervical mucus, slowing transport, and thinning the uterine lining. Plan B will not work if a woman is already pregnant, meaning that there has already been an implantation of the fertilized egg into the uterus. It will not do anything once the fertilized egg is implanted into the uterus, so it is considered a contraceptive and not an abortifacient. It does not harm existing pregnancies. The side effects are similar to the mini pill, but you are only taking one dose, and the dose is much higher than what you'd get in the combination pills. There's often quite a bit of nausea, and it is recommended to take it with food. If the patient throws up within 2 hours of taking the dose, they should contact a healthcare professional to see if they need to repeat the dose. It is possible that you may see changes in your next menstrual period due to the disruption of the hormones. Plan B is most effective when taken within 24 hours of unprotected sex. It is not 100% effective, but it does reduce the occurrence of pregnancy by about 75 to 89%. And as the slide says, it's the most effective the sooner it can be taken, but it does need to be taken within at least 72 hours. Plan B is available without a prescription at most pharmacies and drugstores without an age restriction. So let's review, putting everything together, thinking about why is it so important to take Plan B as soon as possible. So as a reminder, Plan B can be taken within 72 hours of unprotected intercourse. However, it's most effective the sooner it's taken. Thinking back to the mechanism of action, it works like the progestin-only mini pill, so it may prevent ovulation, but it's also effective in thickening the cervical mucus, slowing the transit in the fallopian tubes, and thinning the endometrium to prevent implantation. Remembering that the travel of the fertilized egg down the tube and implantation can take 4 to 7 days, and once the fertilized egg is implanted into the uterus, Plan B is no longer effective. So that's why Plan B is so time sensitive, because once the egg has already implanted, it is not going to be effective. So we've covered a lot of details in this presentation, but to summarize, hormonal contraceptives are a widely used medication. They work by interfering with the normal menstrual cycle. They are available in several different formulations and dosages, and some formulations may be more appropriate for some women based on certain conditions. Hormonal contraceptives have adverse effects, but also can have positive effects as well. Emergency contraception is a high dose form of a commonly used progestin in oral contraceptives.